Hello, and welcome to Health Advocate X's second XCenter series, Trauma Informed Care. I am excited that you are joining us for this session, in which we will have Annie Lewis O'Connor, who is the founder and director of the Care Clinic. And she's going to be talking to us today about understanding and recognizing trauma in healthcare settings. We're going to be covering a lot of ground today, but we have three primary objectives that we're going to focus on. First, we're going to learn language and skills to identify trauma in healthcare settings. Second, we're going to hear some of what is happening in healthcare settings and what those professionals are doing to address trauma. And lastly, we're going to be identifying specific strategies to help patients navigate care and help avoid creating additional trauma in the healthcare delivery. So Annie, we are excited that you are here today, and I'm going to let you take it away.
Thank you so much for this warm welcome. I am thrilled. Greetings from the East Coast. I'm in Boston on a gloomy day, so it's very nice to be with all of you. I want to start by prefacing this talk by saying, talking about trauma, although I understand for many it is hard and it is difficult, it's necessary in that we can find ways forward to help people heal, and not just to help people survive, but to help them thrive. And in that spirit, if anything makes you feel uncomfortable today, please take care of yourself in ways that you know works for you and suits you well. As I talk about trauma today, there's many definitions out there if you went to search it. I really am going to talk about sort of the perception that my team has had when we think about trauma. SAMHSA has a definition of trauma, which we very much think is encompassing. It states that individual trauma results from an event, a series of events, or a set of circumstances that's experienced by an individual as physically or emotionally harmful, perhaps threatening, and has lasting adverse effects on an individual's functioning. And that can really impact one physically, socially, emotionally, or spiritually. And sometimes I will use examples such as witnessing an event. I'm in Boston, and I was not at the Boston Marathon when the bombing occurred. However, as somebody born and raised in Boston, that had quite an impact on me and took me a little bit of time to process what happened that day. So you don't have to directly, you can witness it. Now, when my team thinks about it, and this is how I hope many of you will think about it, that trauma can happen at the individual level, right? So the loss of a loved one, a motor vehicle crash, a poor diagnosis, right? Individuals every day around the world are experiencing some forms of individual trauma. So it's not unusual. Interpersonal trauma is really where I've spent my career, and it's looking at violence across the lifespan. So think about child maltreatment, teen dating violence, sexual violence, domestic violence, elder abuse. It happens in the context of an interpersonal relationship and often is not by a stranger, which is really something that people think that, if it's sexual assault, it must have been a stranger. In fact, in this country, most sexual assaults are by someone known to the victim. And then collective trauma. I think about sort of the world right now, watching what's happening in Palestine and the Gaza Strip, and collectively, we all are experiencing that in some ways. The pandemic was a collective trauma for us, right? So you can think of things that are happening maybe worldwide that is not directly impacting you, but because of social media and because of how we receive news, collectively it impacts us in some ways. And then structural. And I think that this is the one, this was not on our concentric circle when we first started thinking about trauma. Certainly the pandemic got us there to think about structural racism, to think about how oppression and all the isms that are impacted are structural. And so we felt that it was important enough to include that. Now, please understand that these are not all mutually exclusive. Actually, in fact, many of them are intersectional. Okay, so this, when you hear me talk and mention trauma today, I'm thinking about it through this lens. Okay. So when you hear trauma-informed care, and I understand that many people have heard about it, you might have heard about it prior to me coming to join you today. I'm going to dig in maybe a little deeper. I really think as trauma-informed care as sort of this philosophical shift in how we work with, if you call them clients, patients, customers, really shifting it from what is wrong with someone, right? Because that in and of itself just doesn't feel good, right? And shifting that to what happened to you and how has what happened to you impacted you? Can you like feel that shift of the difference? We're doing a lot of work here in Boston, and particularly at the hospital I work at, to really ingrain this people in our new trainees and providers right out of the gate. People don't like to be thunk about as something being wrong with them, right? They want to tell you there's a story or a narrative to what's occurred in their life and then explain to you how it's impacting them. And then that's where we can be extremely helpful. We have lots of data. We know that trauma exposures, as I said right out of the gate, are pretty pervasive. There's world studies and surveys done on populations. This one is out of 2022. You're looking here at 22 countries, so some 65,000 people responded. And look at this, the lifetime trauma exposure is at 71%. Now, we believe that that could be even higher, but that some people may not classify that something going on in their life is traumatic, right? So we always feel that some of these numbers that we see on prevalence and incidence are underestimated. We also know from this survey, this was done, a mental health survey in 2016, and many of you may know we're very behind in data because it takes us years to collect it, and then it takes us another year or two to analyze it and then get it into the literature. I believe that this mental health survey is going to come out with a new one very soon. But again, you can see that the exposures are pretty high, close to 0.75%. And we're going to talk a little bit more of ACEs. I understand that some of you may know about it, some not. So I am going to specifically talk about ACE experiences. This first study that was done in 1998 really was instrumental in how I practiced and how I thought about young adults I was caring for, actually giving some sort of credence to how these young people I care for might have been impacted in their childhood, and that some of the behaviors I was seeing in the high risk category, for example, might be related to experiences they had as a child. So this study, for me and many in the field of trauma, has really informed us well, and many replicate studies have been done. But this first study, I just want you to all know, this was done at Kaiser Permanente and done with the Center for Disease Control, and it was done on a white, employed, housed, insured population of white people. And look at what they found, that at least 63% had one major life trauma exposure as a child. And I'm going to show you those categories in a minute. And then another 20% in that study had at least 3 of these lifetime traumatic events. If you haven't read anything, on this topic, a Google search will bring you to the many papers that have been published on this. And I think we're close to 90 papers published on ACEs. So here you go. This was that study I was just talking about. There were 3 categories: abuse, neglect, and household challenges. And under each were these manifestations, if you will. And so when you add them up, there's 10. And if you had all 10 of these, it would be fair to say that your childhood wasn't great, right? But I've also noticed that sometimes it's only one. It could be just there was sexual abuse going on in the house, or that there was a parent struggling with mental illness or substance use disorder. And so while the population study shows that increase in ACEs is increase in health consequences, we also know at the individual level that 1 or 2 could be worse than 6. And that has to do with people's resilience, resources, and ability to heal and thrive, right? This study also showed the connection between heart, lung, and liver disease. And I remember the first time I gave a talk on this with a bunch of cardiologists. I had a line out the door because cardiologists said, "Oh my gosh, I've seen this in my patients and never thought to make that connection between what happened in their childhood and how it's affecting them in their adulthood." And they also have strong connections to obesity, diabetes, depression, and substance use. And no surprise on depression and substance use, right? So the study, as I told you, had nearly 2/3 of those surveyed had one of those major events that I just showed you, one of those 10 ACEs. And this, again, based on population, the more exposures you had to those 10 ACEs, the higher the chronic illnesses and medical diseases. Again, though, remember, at an individual level, you could still see those, high morbidity with healthcare related to 1 or 2 ACEs. But overall in the population, this is what they found. I'm putting this in because this is more recent. Okay, that was 1998. Now let's fast forward. Here we are in 2019. And the Center for Disease Control said, well, let's look and see where we are now. That's what we found in 1998. And as you can see here, again, multiple states participated in this study. My state didn't. I'm still asking questions on why we didn't. But again, you can see 61% are still reporting at least that one ACE as a child, and then another 16%, 4 or more. We know that in American Indians and Native Americans, Alaskan Indians, and people of color, that these numbers are significantly higher. I've had the privilege to do work in Navajo Nation in Shiprock, New Mexico, and I can tell you this number here for 16% reporting 4 actually goes up to 66%. So, and I think some of that is probably related to social determinants of health and structural racism. Now, I'll explain to you an odds ratio because I know not everybody gets that. An odds ratio is, let's look at one here, the best way for me to explain it. Depression. If you have 4 more of those ACEs, the likelihood that you're going to have depression is 5.3 times that of people that don't. Okay, so you can do that with each one of them. If you have 4 more ACEs, you are more likely than someone with no ACEs to be almost 2 times more likely to be a heavy drinker. Again, these numbers change dramatically if you are looking at Alaskan Indians and Native Americans and people of color. You can put the depression up to, I think it's 18 in the Native Americans. So all of these numbers change dramatically. So that should be a wow. It definitely wowed me. And if you are interested in a certain population, say if you are, as I was when I started working with Navajo Nation, I looked up ACEs in Native American Indians. And lo and behold, someone had done the study. So there's a lot of data out there on ACEs. We know in childhood trauma, I'm not going to read all of this to you, and you will have a copy of these slides that you can refer back to, but I hope you are all as traumatized as I am when I read these. I have been working in the area of physical and sexual assault my entire career. And what is incredibly bothersome to me is that these numbers just don't change. Despite our efforts to, do prevention work, we still are struggling in this country when it comes to physical and sexual assault. We still have around 2,000 women a year in this country that are murdered by someone that they knew that loved them. And that number has not changed much. It might be off 50 or 100 year to year, but it's been pretty consistent. And now we've got this whole thing of the internet. And I was happy yesterday to see that Instagram is really putting in some safety measures for kids. And they have really put a lot of thought into this. So awesome. I wish we had done this years ago, but finally we are getting somewhere with that. And then natural disasters. California is always dealing with fires. I was in Nevada last year, and I had to get myself out quick. And I have never been that close to a fire as a woman that lives in the city. And so every day, right, there's this exposure if you're living in some of these high-risk areas with climate change. We know that intimate partner violence, and this is really my longtime interest as a nurse practitioner, is the incidence and prevalence. And as you can see, the numbers are still really high, and these we do believe are definitely underrepresented. I have someone sitting in front of me in the ER that's just been strangled and has bruising all over the body, but is telling me she fell. So we know that there's a lot of stigma associated with talking about what's going on, and our goal is never to get anybody to disclose and to share with us. Our goal is to make sure they're safe, provide them with resources, and make sure that if something happens again, they will feel comfortable coming back to us. And that is really the goal. So if I could see you all, I would ask you, how many of you think you have unconscious bias? And I'm going to put my hand up. And I have to say that when I first started asking people, not everybody raised their hand. Nowadays, I pretty much get everybody to raise their hand. You can't help it. It's just how the brain works. And so people are like, well, what do you want me to do about it? I want you to be aware of it. I want you to be like, oh my gosh, I'm doing it. I'm going to share a quick story. You can tell I'm a storyteller. I went out to the emergency room one day and I said to my colleagues, I'll be right back. I'm going to go see what's going on in the waiting room, right? Just get a pulse check. And I went out and I went on the other side of the door and I looked around the waiting room. And then I walked back in and I walked up to one of the attendings and I gave her a full spiel on who's in the waiting room. And she looked at me and said, did you talk to all those patients? And I looked at her and I went, no. That was a epiphany for me. She goes, so you just are giving me all that based on you just going to the door and looking at people? And I'm like, yeah, I did just do that. And that really was a game changer for me. I actually took you'll see it on the slide there at the bottom. There is a link and you can go test yourself. And that's what she advised me to do. And I did horrible. I did horrible. So I started like reading books about it. I started raising my consciousness and I retook the test. and I did much better. And I want to take it one more time. But it still doesn't mean that my immediate thought doesn't go to my unconscious bias, but I feel like I catch it and I catch myself. And I do think that's a good thing, because when this seeps into a healthcare setting, you could have the wrong diagnosis. You can not give the patient what they actually need and deserve, right? It causes harm. It absolutely causes harm. And we don't want to do that. We're in this work because we want to help. So it's that automatic response that thinks you really got actual data, when in fact you need to be more curious and seek to understand more than making those assumptions. So please take the test. Take it with a friend, take it by yourself, and then talk about it. And it's free. So I want to talk about stress versus toxic stress, because you will all be seeing patients at probably not the most optimum time in their life, right? And you are being asked to provide the services you provide because that support is needed. Now, stress is really normal. We were built, and our minds were built to be able to handle it and tolerate it. However, when there is a steady dose, let's go over here to toxic. If you go home every night and you're hearing gunshots, or you are hearing alarms on cars go off, and it just doesn't feel safe, you're in a state of toxic stress. If I was to hear a gun go off in my neighborhood, I would definitely be here, because I'm not used to that. Some people that are living in environments that are unsafe get to a point where it's tolerable because they're just used to it. Isn't that sad? But I want you to be aware of, when you see people that are over here in this toxic stress, that body needs to settle some before your interactions are going to be helpful. So you can't just go forward, well, I'm here to do this, this, and this with you today. You need to recognize it appears that you have a lot going on. How about if we take some breaths together before we go forward? You want their feet to be on the ground. You want them at least to be in this tolerable state, because if in a toxic state, you're just not going to be effective, because their endorphins are flying, and then they're in their fight, flight, or fawn mode. So we want to settle the body. I have patients that arrive at clinic and they're stressed out. They're late, they missed one bus, they were afraid they weren't going to get seen. And I'm like, okay, let's spend a little time and settle. And then we can get to why you're here. I hope that makes sense to you. We often just jump in, and it's not ideal, I can tell you that. All right, this looks really busy and overwhelming, but I'm going to walk you through it. Stress happens. I probably have at least one stressful thing that happens a day. and normally, you will have a behavioral response to it. I'm not really a fighter. I'm one to stay in the fight and resolve it. And then some people use some of their behavioral responses. Let's go out after work for a drink, or we have responses. Some of them are healthy, some could be unhealthy. But we also have this physiological response that we can't always control, because as soon as our frontal cortex, feels a threat, say you're getting out of your car or off your bike, and there's a dog, big one, coming at you, and it's barking, you're not going to say, oh, he's a cute little dog. No, your frontal cortex is going to go danger, and your amygdala, which is the response center to stress in your brain, is going to kick out endorphins and epinephrine, which dilates your pupils, makes your palms sweat, and you feel like you could have a heart attack because your heart's never beat so fast. All of you have probably had that feeling. I get that when I go on a Ferris wheel. Like, I don't like when we come over the top. And normally we get back to what's called allostasis. It's like the threat is gone, I'm breathing slower, my pupils go back to normal, my heart rate comes down. But for some of the people you'll be working with, they're in this state of allostatic load, constant stress. And that's a repeated type of stress that makes them dysregulated. They very rarely get to this adaptation. And we know for those people, they end up with depression, anxiety. My goodness, I've been in the field a long time. I have never treated so much anxiety as I have in the last 5 years. I hope all that makes sense to you. Having that dog chase you once is different than that dog coming at you 8 times a day. Can you imagine repeating that cycle throughout the day? So I bring this up because you will be working with people that have these constant stresses. And while you may not be able to sort of fix them, you being able to acknowledge them and having some tools in your toolbox may help to get them to a little bit of adaptation during what is stressful days for them. I wanted to share with you, and I've learned most of this from my patients. I am also a researcher. Besides being a clinician, I am interested in how the healthcare system can be more therapeutic than it is. And so then we have to be honest. um, and and the thing is, we ask people to retell their horrific stories over and over. So you're in the ER, now you're going to get admitted and you're on the floor, and the floor people ask you, and now you're going to be discharged home and you're going to have services coming. And we ask and ask and ask. You could only imagine how that must feel if you were asked to tell something bad that happened to you in your life over and over again. So we don't want to do that. And we are really making great efforts here in Boston, that you are to page that person, you are to read the note, you are not to be asking a patient to retell. And we're even, with the patient's permission, going into rooms as a team so we can all hear the story if the patient agrees to that. I hope that makes sense. Many of, and I think this happens at least weekly, sometimes daily, that people will make referrals to me in healthcare. And at the end of it, I'll say, can you tell me the patient's name? And they go, hold on. And they're typing away. Oh my goodness, please, please try to embody the patient's name. They are a person. They're not a gallbladder. They're not a homeless person. They are a person with a name. So push yourselves to really, and if you forgot it, just say, I'm so sorry. Could you tell me your name again? I forgot. I'm sorry. But do not refer to them as diagnoses or what their issue is, rather than being as a person. Um, I'm not going to go through all this lack of privacy. Oh my gosh, right? I mean, I am sure that what's going on at my hospital is going around the country. 40 to 50 patients in the hallways. Can you imagine? Like, that wouldn't work for me. I really like privacy. And if you're going to ask me private questions, not in the hallway. So our environment is a very stressful environment these days. We have much more demand than we have supplies of providers and hospitals. So not fun. Procedures that might be normal to some of our healthcare providers are not routine to patients. You know, sorry, we're just going to put a little catheter in your arm. Um, well, people from Haiti are used to running, around with really high heart rates and being dehydrated, and they don't use IVs. They just don't. And so now an immigrant to this country that needs to come in for and gets an IV put in, it's a big procedure to them. They have no understanding of it, no knowledge of it. They've never had that experience. And then, of course, look what we do. Like, can you turn this way? And I'm going to touch and palpate. And oh, could you put this lovely Johnny on? It's not something that makes people feel warm and comfortable, right? So one of my favorite pictures, and thank goodness to some artists that were in the hospital helped me create it. When I was a kid, I actually, until I was 23 years old, had one family doctor. One. If I had a broken thumb, which I did, and ankle, my one doctor did everything. Helped me with my acne, helped me with whatever my issue was. And then in my lifetime, I have seen that we have taken the body and healthcare and broken it into sections. And any of you that have aging parents are probably looking at the calendar going, oh my gosh, it's like a full-time job to be an elder today. And it's all spent going to all the different specialists. I share this with you because I want you to recognize that it's hard for our patients. It's hard for them to navigate a cardiology along with my psych, along with my primary care, and I'm now pregnant and I, fractured my ankle. That is a lot of work. So when people don't show for appointments, I don't want the first thing for you to think is, oh, non-compliant patient. I want you to think, I wonder what the obstacles were for this patient to keep this appointment. Because it could be all of that and food insecurity, violence going on in their life, housing insecurity, etc. So let's not be blaming patients, but understanding that our system is not an easy one to navigate. And I think as advocates, you will be doing some of that work. I know I do a fair amount of that every day, is helping to coordinate for patients because it's too much. So how can we shift, knowing that our system is tapped, knowing that our resources are thin, knowing that many people have complex healthcare needs, that you're not just going to have a general practitioner take care of you, but you are going to have all those specialists. I think one thing we need to be aware of is use some universal precautions, if you will, or universal awareness that all patients can be treated through a trauma-informed care lens. Okay. I will sometimes get calls and they're like, oh, yeah, this patient, horrible life of all kinds of traumatic events. So we'll use trauma-informed care. And I'm like, well, you should be using it on every patient because you may not know. It may take a while for someone to tell you about the horrific things that have happened in their life. So don't make an assumption. Rather, just treat everybody the same. And they don't have to tell me they have trauma for me to use that framework. There are these 4 R's. One is to realize that trauma is widespread and it's pervasive, right? You saw the definition I shared with you. When you think about that concentric circle of individual, interpersonal, collective, structural, right? It's all around us. It is all around us. So if you can realize that and then recognize that there is a structural piece to it, right? And structural racism has definitely impacted populations that makes it difficult. We've got to change some of that structural stuff. And so we're doing that in my organization. We're recognizing that and moving forward with trying to become a trauma-informed organization. And then we have to know how to respond. So here I want to take a quick pause and say, don't think or feel like you're going to rescue people. Your job is not to rescue them. Your job is to listen, to be empathetic, and where you can, be honest. Connect them to resources. But when you can't, I have many patients that are unhoused. I am upfront with them. If I hit megabucks tomorrow, I'd build housing that was affordable for people. I don't have that capability, but we do have a housing specialist, and I can provide you that name. So build your resources so that you know, but you can't rescue people. You can only empower people with education and resources and support them on their journey. So I always say, don't get out in front and pull them. Don't get behind them and push them. Just walk beside them. And then our ultimate goal is to not re-traumatize them, right? Whenever we have that opportunity, we really want to think about how we ourselves could not re-traumatize someone. So quickly, we're going to go through 6 principles. These are the 6 principles of trauma-informed care. When they first came out, I had them on my phone. I taped them to my phone. Now I have them memorized, but I never wanted to forget them. And I wanted to make sure that I was always thinking with these 6 principles in mind. So let's just go through and look. Safety. Not only is it important that the patient is physically safe, but they need to be psychologically safe. And if they feel threatened and they're in an emergency room with something going on, they may not be psychologically safe. So we want to focus on thinking about that. And before we are doing any intervention with them, that we have them feeling physically and psychologically as safe as possible. Make sense? Now let's look at trustworthiness and transparency. And this to me is something we can always do better at. And sometimes you might not feel comfortable with it. So no, this is a journey you'll be on in trying to use these principles. So one thing I thought about is when the computers came out in healthcare, that computer came between me and my patient. Because prior to that, there was no computer, there was a paper chart, and we were looking at each other. So I decided, why can't I share the screen with my patient? Well, one is there was no seat in my clinic, and the screen was too small. So I put in a request. I asked for a bigger screen, and I asked them to get me a different desk where 2 chairs could come up. And now I pull the patient up with me, and we're looking at it together, and we're side by side. And if I'm doing an assessment that requires them to answer a question, they can see the question. And we have the capability of actually switching languages, which is really cool. So I think that wherever you can build the trust, if you can't do something, say, I am not able to do that. However, I will try to find somebody that does. Patients just want you to be honest. They don't want you to give them the answer they're looking for. They prefer you to be honest. And that's how you build that trust. Peer support. Now, I think you're going to be doing a lot of that. And I certainly do quite a bit of that. If I have someone that's in a intimate partner violence, there's lots of peer support out there for that. I make sure they have those resources. It's not my job to make sure they get there, right? It's their autonomy that I have to respect, that they might not be ready today, but 2 months they might go, and they have the information. And we want to make sure we follow up when we are referring. I refer patients to AA. I don't just refer them, I refer them and then I say, were you able to go? Not did you go? Were you able to? And how was it for you? Because sometimes at one meeting they might have a bad experience because it's a woman and most of the people there are guys, right? So I want to assess. Just because it didn't work at that one doesn't mean it wouldn't work at another one. So as we do that, circling back, really thinking about how we collaborate in power dynamics. I've thought about that a lot in my career. For that reason, I don't wear a white coat. I think the white coat denotes power. So I don't wear it. Sometimes in the winter if I need pockets, but I'm very uncomfortable in it. I also think that you should sit and not stand over someone. I think if they're laying down, to either lower the bed if they're, you want to make the space a space where that power dynamic is sort of leveled, if you will. When I send messages to patients, I take all my credentials off it. I know what my credentials are. They're not even going to know what any of those, those credentials mean. So why put it on there? They know my role. That's what's important, is what my role is. And then obviously shared decision making without judgment. If you have someone you're working with that's a diabetic that's eating a Milky Way, you don't want to judge that, but you want to understand, have you ever tried chocolate that doesn't have sugar or lower sugar? You don't want to shame people. So if you don't know what to say and you feel like what you're going to say might shame them, then just hold back. And you'll learn some of those things because you'll see the reaction of people you're working with. So we get a lot of patients that are not complying with the treatment plan. Perhaps the treatment plan wasn't what the patient wanted. It was probably informed more from the provider to the patient than with the patient. And when we do it with, we do a better job. I love this one. Every one of us here today loves to feel empowered, loves to have choices, and wants their voice to be heard. Do you hear me? Do you see me? And that's pretty easy to do. Yes, I do see you. I hear your concerns. And I'm here to help in the best way I can. Share with me what you think I can help you with. And then answer it honestly. Acknowledge the people that you work with, their strengths. And how do you do that? You ask them, tell me about some of your strengths. Now, if you get somebody that says, oh, I don't think I have any, push them a little bit. Have you ever played sports? Have you ever played an instrument? Do you sew? Do you cook? Push them a little bit, because I've not met a patient in all my years, almost 4 decades, that I haven't been able to pull a strength out of them. That changes the dynamics of your interaction. Patients that I ask what are their strengths look at me like, wow, nobody's ever asked me that before. Thank you for asking. And then big one, right? How do we acknowledge cultural differences, historical backgrounds, gender acknowledgement? We all need to do some work in that area. We all have our things that we're uncomfortable with, and something that makes you uncomfortable, that's good to know. There's classes out there. There's mentors out there. There's ways to learn. So be open to that. Be most critical of yourself and what else you need to be able to apply these principles in ways that are meaningful to the patient. Be aware of your unconscious bias. The way home from work, I shut off everything. I just drive. And I say to myself, what went well today? What am I proud of? What didn't go so well? And what would I do if that came up again? That's my quiet time with me, checking in with myself. And it will most certainly make you feel better about the work you're doing. And then we're getting close here to wrapping up. I really like to look at our policies and procedures. As you embody trauma-informed care and you've got a new policy or procedure coming out, take those 6 principles. Look at that policy. Does it align? There's not a policy I look at that comes out of my institution that doesn't need some work. So where I can, I try to make sure that the TIC lens is incorporated. Consider who the stakeholders are. Sometimes we should be asking the people that are the end users of what we're developing, will this work for you? People learn differently. We know that about our children in school. There's not just one way to teach kids. They all learn differently. I have a patient advisory board that informs my clinic. So if I'm developing a new brochure or I'm going to do something new and different, I run the idea by them, and boy, it always is helpful. And so you wanna always periodically go back and look at your policies, your procedures, what you're doing. Who is it working for? I always say this, who is gonna work for? And then the next question has to be, who is this not gonna work for? All right, so both sides. Um, I know a lot of people like people to disclose and answer their questions and tell the truth. Well, quite frankly, that is asking a little bit too much. Those disclosures are what people want to share. They're going to share when they feel safe and they feel comfortable. And so I often impose upon on clinicians that universal precautions, just because they don't tell you, don't keep jabbing at them. Do not keep asking them. And really what I educate people about is, I noticed you're having these increase in headaches. Is there any stressors going on in your life that could be causing that? Broad, not direct inquiry, but broader inquiry. So our takeaway concepts here: never, ever, ever worry alone. I just had 3 students start with the clinic. And at the end of it, I said, so what are the main concepts? And they all said, we're not going to worry alone. Should never worry alone. You're part of a system, you're part of a team, and you need to have each other's backs. So do not worry alone. Um, you're not going to know everything at once, but be curious. Suspend judgment. Be curious. Please try to use, and when you don't use person first language, apologize. Don't ever say the homeless person. The person is a person first, the person that is unhoused, the person struggling with substance use disorder, not the addicted patient, right? That's labeling, pejorative terms you want to stay away from. And again, be curious, ask questions, seek information to your questions, and build in a way for you to process when things are difficult. Know who your people are, know who you can go to. I just love this. I've been using it for a very long time. I keep thinking I'm going to find a better one, but this just says it for me. Don't judge me by my successes, but you judge me by how many times I fell down and I got back up again. And boy, did Nelson Mandela did that. And so do so many of the people you work with. They have fallen, they have gotten back up again. They have strengths. And I love watching people soar when we do put those TIC approaches into healthcare. They do soar. So I want to wish you all the best, all of you. And there's lots of references and lots of reading here. So you'll have those. Be curious and do some reading. And again, I wish you all the very best of luck.
Thank you so much for that, Annie. That was absolutely wonderful and incredibly helpful. There are so many things to discuss here, and I do want to take just a little bit of time and have a bit of a discussion with you. One of the things that seems to be at the center of trauma-informed care is empathy, is compassion, is, as you said, having that curiosity and not judgment. I work with a lot of vulnerable populations, and I always take the approach of care. So I'm going to ask questions about care over curiosity. But I
Mm.
think there's very careful line there, but it really does. I think they can come back together. So why do you think the coming at a patient with that curiosity, how does that help a patient?
That's such a good question. Um, you know what I think it does, and I hear this from patients, right? Because I am a clinician, is right away it decreases the stigma and bias. I will use the example of a person of size. A person of size will tell you, and it's hard to listen to, how they've been stigmatized in getting their health care. When you approach a person of size with curiosity, tell me what you want to accomplish. Tell me what you feel is a good way forward for you, and how can I be supportive? By having that curiosity, I think you level out stigma and bias that is ever so present in healthcare. It just is. Um, so yes, I think asking those questions and creating that dialogue means you're open to actually doing that, to having a dialogue with the patient instead of being prescriptive and telling them what they should do and how terrible it is that they haven't lost weight, right? So, and that's a breath of fresh air for patients.
And I love this. This goes all the way back to the beginning of your presentation where you talk about that philosophical shift. It's not what's wrong with you, but what's happened. And you brought that up a couple of times about, we do have patients that are late, they're not doing what we're asking them to do, so they're non-compliant. And so rarely do I think is there a dialogue and a conversation about what were the barriers? What happened? What got in the way of this? And just shifting that thought
Mm,
automatically to me opens up that door for empathy, right? It's not about a judgment. Like we all have things happen, whether we're traumatized or not. Um, but it's so important, I think, that we have that opening for empathy. Are there other ways that you can see us demonstrating that we're empathetic or different mind shifts that we can have to show our empathy?
mm. I think it's so simple. I think we try to make it more complicated than it is. I am so sorry that that happened to you.
Mhm.
How can I help right now? Right? So the patient that is late, we were gonna have a policy that if patients miss 3 or more appointments, they couldn't make an appointment for 6 months. I'm like in a meeting and I'm like, oh my God, that sounds so punitive. Like, do we have any understanding of why? Because clearly they want an appointment. They've called 3 times and made it. So we did stand down. And we found that for people on state assisted insurance, making an appointment at the end of the month, they weren't successful because they didn't have money left for the bus and the train. Right? And sometimes we put these policies and procedures in place, like I said, who is it going to work for? And who is it not going to work for? So we have to push ourselves to say that our policies and procedures do not work for everyone. And so for those that it may not work for, what is it going to look like? That's fair and equitable. Having a policy, I can drive, I can park my car, I can afford to pay the parking fee. So yeah, that's going to work for me. But the woman with 3 small children in tow who's at the end of the month and the end of her check, that's not going to work for her. So we started moving those patients up further in the month.
Brilliant. What a an amazing way to identify the problem and then think about the patient, like what could be getting in the way and how can we help. And it doesn't cost anything extra. It doesn't cause
Yeah.
a whole lot of policy changes. It's simply, what if we move these earlier in the month so we're not having to make a decision between those last few dollars and getting to that appointment. I love that example. Thank you for that. I
Yeah, you're
also love
welcome.
that you bring up the simplicity of empathy, of just listening and saying, "You know what? Wow, I that's a lot. You're going through a lot." And you don't so often people think that they have to be able to walk in that person's shoes, but we really can't. And you said that too about just don't walk ahead of me, don't walk behind them, just walk alongside so that so the patient isn't worrying alone. We don't
Mhm.
want to worry alone, but they don't need to worry alone either. So it can be, as you said, just as simple as I'm here with you. I'm going to brainstorm with you and I'm going to give
Mhm.
you the space that you need. I'm going to see you. I'm going to hear you. I'm going to value the experiences that you're having. So thank you so much for that. I think that's really, really helpful. And as advocates, I think all of us do the work that we do because we are intentionally empathetic. But I don't know that everyone always thinks about how we are empathetic in these traumatized ways. Because a lot of times people of a lot of trauma, and I'm a trauma survivor myself, some of the times that I'm at my worst, I'm not my best person is because I'm being impacted by all of these things that are happening. And that's
Mm.
really when we need the care and compassion the most.
Mhm.
So
Yeah.
I
Yeah. And be, know that little tiny things are big to patients who are not getting that. They may not be getting that at home. So when I say I care about you, in domestic violence, many of my patients are going home to the abuser. And I just want them to know that you deserve better, whatever path you take, staying, leaving, going back. I am here for you unconditionally. My job is not to judge your decisions, to support them, even when I don't agree.
yeah,
Even when I don't agree.
that's bottom line, it's not about us.
It's about us.
It's not. It's I'm here to help you.
Yep.
And as you said, I can't rescue you. I can't, I think we all wish we could just hit a button and
Oh,
hit the
yeah.
easy button and just poof, you have everything that you need. The system is flawless and it supports everybody but unfortunately that's not the world in which we live. But though we can't fix the entire system, and it is a very broken system, as you've identified, we can be empathetic. Everything that you're putting forth here and everything we're going to be talking about in other sessions as well for this series are things that we can do and ways that we can
Mhm.
help right now. So, any additional tips or advice that you want to give our audience?
I guess the last thing, just based off what you just said, is you may never truly know the impact
Mm.
until you're at this a while. But with social media and things, I actually should make a slide of it, but it really does make me cry tears of joy. That patients that I cared for many years ago that I didn't realize that me saying to them, I care about you, I'm here for you. I have gotten emails and reach out through social media. 10 years later, I am married, I have kids, and I just want you to know that you had a huge impact on my life. And I think, like, what did I do? And that's all I did, was be there unconditionally for them, meet them where they're at. And so I want you to know you will have that experience, but I didn't have that, as I was doing the work. But it certainly has found its way to me over my career. And boy, does that make me feel good,
That's
because
amazing.
it was simpler than I thought. It wasn't as complicated. I didn't need all those degrees after my name. I really just had to be a kind, thoughtful, empathetic listener and genuinely care about their well being. That was it.
That's amazing. Thank you so much for that,
Oh,
Andy.
you're
Thank you
so
for your
welcome.
time, your work, everything that you're doing. We greatly appreciate that. So we hope everyone
Thank you.
will join us
Thank you.
in our next session. So thank you.
All right. Have a good day, everyone.